I was asked to present a complication involving tissue disruption. The following case is from several years ago. The case involves a 75-year-old man with severe AS who had worsening dyspnea on exertion. His echo showed an EF of 40% with a mean gradient of 43 and a peak velocity of 4.5 meters per second. Cath showed mild coronary disease, and a TAVR CT demonstrated an annulus that sized to either a 29 mm S3 or 34 mm evolute. His iliofemoral axis was large, but there was some concern about the tortuosity of his thoracic aorta, which was suggestive of a pseudocoarctation. He had a number of comorbidities. Notable comorbidities were his chronic kidney disease with an elevated creatinine of 1.8, need for warfarin post-procedure due to his history of atrial fibrillation, peripheral arterial disease with claudication, the need for HOMO2 due to his COPD, chronic steroid use due to his rheumatoid arthritis, mild dementia, and thoracic ectasia. His STS score for mortality was elevated at 10.8%, and he was deemed to be extreme risk for open heart surgery and felt to be a reasonable TAVR candidate due to his good baseline quality of life. The patient was interested in pursuing the TAVR procedure. This is a 3D reconstruction of the thoracic aorta, which demonstrates several segments of extreme tortuosity in series. We had some serious concerns about being able to successfully deliver a TAVR valve via the transfemoral access due to these areas of tortuosity. We reviewed the access options as a team for pluses and minuses. Obviously, femoral would be the most comfortable, but we were really concerned about not being able to navigate this tortuosity, and we didn't really know what would happen as far as risk if we were able to straighten out the vessel. We had a lot of experience with subclavian access, left more at that time, but the right obviously was going to be the more favorable option due to avoiding the areas of tortuosity. Apical would have been a great option, except that he was on steroids and had COPD, but it would have allowed us to avoid the tortuosity. Our team had not done any direct aortic access or transcarotid access at that time. And transcaval was something we were doing, but it didn't really offer any major advantage because you'd still go through the segment of tortuosity. After reviewing all the options with the patient and the family, we were able to rule out a few options. As I said, we weren't going to do transapical because it was high risk for this particular patient. We were not doing carotid access. The patient was really interested in a transfemoral option. We discussed the risks with him, but ultimately decided to go along and do that. Our backup option was going to be right subclavian access. This live fluoro image demonstrates us wiring via the left radial access with a Woolley wire, and then exchanging it over a catheter for a Rosen wire. Notice how the Rosen wire really straightens out one segment of tortuosity in the aorta. We then used a second Woolley wire via the left femoral artery and navigated through another segment of tortuosity. We exchanged that wire for a Lunderquist wire with an exchange catheter, and notice again how this second wire really straightens out a second segment of the aorta. One concern of mine was that we would be able to deliver the Edwards valve up to the thoracic aorta, but then not be able to traverse the segment of tortuosity. So we ended up using an Edwards delivery system without an Edwards valve, just to prove that we could get the system through. And then we used that system to perform our BAV. This is over a third wire, which was a Lunderquist used in the LV for support. After a successful balloon aortic valvuloplasty, we introduced the 29 mm S3 valve on the Edwards delivery system and navigated through the segment of tortuosity. We were able to cross the aortic annulus using a system of buddy wires, and then we're able to successfully deploy the valve. The screen on the left shows the TEE demonstrating no paravalvular leak, and the screen on the right demonstrates good position of the valve. Before we gave up access, we decided to shoot an aortogram. We pulled the LV wire back to allow some of the segments to retwist, and then we wanted to prove that there was no extravasation of contrast or blood. The patient did really well leaving the OR, and unfortunately, a couple hours after being in the ICU, started to decompensate. He had a decreasing oxygen saturation, an increasing work of breathing, decreasing H&H, and required pressors, which was concerning for bleed. Chest X-ray suggested left hemothorax, so the patient was re-intubated. A chest tube was inserted, which demonstrated bloody drainage. And then we performed a CT scan. The CT scan unfortunately demonstrated an area of pseudoaneurysm in one of the segments of unfolding of the aorta. We consulted vascular surgery, who unfortunately felt that there were limited treatment options given the patient's age, comorbidity, and vessel size mismatch. So they recommended a conservative approach. We held antiplatelets and anticoagulants. Fortunately, the patient did well. His H&H stabilized, the output in the chest tube decreased, and his hemodynamics improved, and we were able to get him off of pressors. The chest tube was removed on post-op day 2. The patient was extubated, and a repeat CT scan was performed 1 week following the procedure. Through an abundance of caution, we actually kept him in-house till post-op day 8, at which point we discharged him on just a baby aspirin for fear that rebleeding could occur. He actually did really well. We were able to start him back on Coumadin for his AFib, and eventually we saw him back in clinic at a 1-year follow-up visit, where he continued to do well. In summary, this case highlights the importance of careful pre-procedure counseling, in particular with the patient and their family, especially when you're trying to do something that you've never done before. Although we were able to successfully deliver the TAVR, untwisting the aorta ended up resulting in an iatrogenic tissue disruption of the aorta. Anatomic factors as well as the chronic steroid use likely played a role in this particular complication. We were very, very lucky, and as they say, sometimes it's better to be lucky than good, where we had a positive outcome with a conservative management. In the current era, I would tell you that I would never try this procedure again. Now that we've embraced the carotid access as our alternative strategy of choice, I would absolutely not try to straighten out the aorta again, and I would have embraced carotid access. If there are any questions, please feel free to email me.